I'm going to introduce Tara Whyand. And Tara Whyand is actually the nutritionist on whose work we are all learn, basically. What we did is we took the Net Patient Foundation book, and we translated chapter 5, which was written by Tara, and we localized it. So I don't really want to talk too much about Tara, because Tara's going to show you exactly why she's here.
Thank you. Okay, so thanks everyone for attending this session. It's a bit difficult to follow everyone's amazing stories and work that they do, but I'll do my best. So today really is about the role of the dietitian. Obviously, many of you will know that in the past I've done sessions and videos on YouTube about exactly how to help a patient, and this is more not how to do it, it's about what we do and in terms of raising awareness. Next slide. So in terms of raising awareness, I just want to make you aware of exactly what a dietitian is and how we can help someone with a neuroendocrine cancer. Next slide. So dietitians undergo several years of intense university study and practical assessments to assess, diagnose and treat diet and nutritional problems. So in the UK, dietitian is a legally protected title. No one can use that title unless they've done this long period of study in a hospital and really are confident and passed all of their assessments within the hospital to be safe to practice. Uniquely, dietitians are the most up-to-date public health and scientific research professionals. We know about food and health and disease, and we help to translate it into something that's more practical and more appropriate based on someone's lifestyle and food choices. Next slide. So in terms of dietitians in managing neuroendocrine cancer, so we usually can help anyone with a neuroendocrine cancer diagnosis or any other cancer at some stage of their cancer journey. And I believe, and I talk about it a lot, that everyone should have access to someone that really knows what they're talking about in terms of diet. And that means employing a dietitian as part of the NET team that you see. Next slide. So what can a dietitian help with? Next slide. So I'll go through a few things that we do. So the first one I'll cover is weight management. So within a diagnosis of any cancer, we're aiming for a healthy weight for your height. And that actually differs depending on race and what country that you live in. We have a different system to other countries, but what I mean is be healthy for your country and your ethnicity. Living with neuroendocrine cancer as a chronic disease, is something that you have to. It's a disease that you have to manage over quite a long period often, and there are other comorbidities. For example, in the US, it's more a focus about being a very healthy weight and reducing blood pressure and trying to lose weight. We have less of a focus in the UK about trying to lose weight if you are, terribly overweight or obese. But there may be instances that actually you're more likely to die of a heart attack or a stroke because you are overweight. So we have to bear in mind other risk factors around weight, but we want you to be in general a good healthy weight, and if you are losing weight, then we need to know that we can stabilize it. Often people come to me and they're, you know, very, very overweight, and they're quite happy to keep losing, but then they get to the point where they realize that they can't stop the weight loss, and that's where it becomes worrying. We need to be able to stabilize that weight. And actually, if you keep losing weight, it affects immunity, which is very topical at the moment. And with fat loss, you also lose your muscle, and we need to have that muscle to keep us strong, keep us moving around. We know more about the effects of being underweight in terms of outcomes for NETs. We know less about what negative effect being overweight could have. Next slide. So obviously, I can't do a presentation without mentioning loose stools. It's what I talk about a lot. And I often find that the knowledge around what that loose stool could be is very poor. And there's so many different causes of having a loose stool. And there's so many types of loose stool. So when you have a NET, you may have multiple types of diarrhea or steatorrhea all at once, and different causes from different things like surgery and treatment. So I think it's one of the first things that I do is try to investigate what kind of loose stool we're talking about, because I can't help until I actually have a diagnosis. Next slide, please. So one of the causes of loose stools is pancreatic exocrine insufficiency. So the pancreas can be affected when parts of the pancreas are removed in surgery, or for some treatments like a somatostatin analog, which affects the enzyme release of enzymes that normally would break down fat, carbohydrate and protein. And the first thing that we would do for those patients who have signs of malabsorption of food, so wind, diarrhea, which looks fatty, something called steatorrhea, or continued weight loss after starting these injections. You don't necessarily have to see fat in the stool, you can just see continued weight loss and fat-soluble vitamin deficiencies. We would start them on these enzymes called pancreatic enzyme replacement therapy, PERT. There's a few brands and they're available worldwide. And then we help patients dose these enzymes to how much food they ate. We also help manage the barriers of people taking the enzymes. In the US, I know these enzymes are very expensive to buy. It's better here where we can access them on free prescriptions. There are also problems with them being from a pig source. So although they are allowed by religious leaders, we have to talk about these things with patients and ensure that they are okay to take them and they're happy to do so. I recently had someone that refused to take them because they were very, very strict vegetarian and they just didn't want to go ahead and would rather, you know, manage what they ate instead of having these enzymes. But it makes life very, very difficult, and it's very difficult to manage weight if we go down that road. Next slide. So the other type of loose stool is called bile acid malabsorption. This is a big area. It's not always recognised. And there are three types of this bile acid malabsorption. This is a very acidic, sometimes fatty diarrhea, change in colour of stools to something quite orangey, but it's quite a stinging diarrhea when it comes out the other end. there's three types. So type 1 is where there's a problem in the part of the small intestine, so the very last bit of the intestine called the ileum. That's where the reabsorption of these bile acids normally takes place. But if you remove it, or there's some kind of inflammation, either through cancer or Crohn's disease, which can sometimes coexist as well, then you get this malabsorption, and the acids go into the bowel, they irritate it, and they come out quite quickly. Type 2, this is where there's no known cause, and this is called a primary bile acid malabsorption. Type 3 can result from other diseases or conditions within the abdomen. So often people realise that their gallbladder's been removed from surgery. Often they don't know about that. So it's always good to know and see your surgical notes. Celiac disease, it's not a common disease, but it does occur alongside neuroendocrine cancer sometimes. Chronic pancreatitis or radiotherapy, or things even like small intestinal bacterial overgrowth, which I'll talk about next. Next slide. So in terms of treating bile acid malabsorption, the first line is always a bile acid sequestrant. So that's a prescribed medication from the doctor. And for those people who it doesn't really work too well with, we can use a low-fat diet as well, especially where we're not worried about someone that's been losing so much weight. If someone's very low weight and we're trying to reduce their fat intake, obviously it becomes very hard. If you're reducing fat intake, we have to add in more protein and add in more carbohydrate to get more calories, and that can be difficult. When you're on these bile acid sequestrants, or you've been losing fat in your stools for some time, then we need to be monitoring fat-soluble vitamins as well. So the levels of vitamin A, D, E, and K in the blood. Bile acid sequestrants can, because they're binding to the fats and the breakdown of the fats, they can inhibit the actual absorption of these vitamins. And also we can help treat some of the other causes like celiac disease and pancreatitis. So we can help in multiple ways. It's not just about prescribing a medication. Next slide. So small intestinal bacterial overgrowth. So this is another type of loose stool which happens because there's an overgrowth of bacteria in the small intestine. With bacteria that grow out of control, the hydrogen producing bacteria often cause wind and diarrhea, and the methane producing bacteria, when they're out of control, they produce more wind and constipation. It's more rare to have a methane exhaling patient. So the test is a breath test where you get given a drink and you are exhaling every 15 minutes to measure the amount of that gas in your breath, which comes from digesting, or your bacteria digesting those substances. We don't have any one set dietary intervention to help with this, but we certainly do get involved when people have this diagnosis. And we use probiotics. Some of us use low FODMAP diets, so where we're reducing the fermentable carbohydrates that we're eating. In, I think it's LA, they're doing a lot of research around low FODMAP diets or meal gaps, so giving the gut a rest between meals and kind of starving the bacteria. We don't actually have that research out yet. We don't know whether that works, but they're all kind of techniques that we might use. There's also a thought about fecal transplants. So it's people who are a healthy weight and have healthy gut flora, donating their feces. It sounds lovely. They're then freeze-dried into a capsule and often put down a tube, so you don't taste anything, straight into the small intestine via a tube, and that can change the balance and normalise and improve the bacterial balance in things like SIBO and other things. However, the change doesn't last forever, and there can be a quick improvement and then the gut can go downhill again. So certainly long-term studies need to be done on that, and it'd be interesting to find out how many times someone actually needs that fecal transplant treatment. And also with small intestinal bacterial overgrowth, we know that certain minerals can become low, like iron. We know that folate can become high in the blood. We know that B12 can become low in the blood. So if we are able to run blood tests, I know it's sometimes difficult in some hospitals, or where you live rurally and you know your GP surgery can't send off results so easy. But we can help with multivitamins and things like that if needed. Next slide. And then there's the topic of syndromic diarrhea, and I've put that last because often these other things are a cause of diarrhea rather than the syndrome. So if we're talking about someone that's at risk of carcinoid syndrome, they may have other things causing a loose stool, especially when we think actually that their tumour is being controlled, that they're on a somatostatin analogue or other treatment. Obviously, if those somatostatin analogues stop working so well, then we would start thinking about carcinoid syndrome. And some people don't want to have the injections, and some people, you know, can't have because of side effects. So where we think that there's syndromic diarrhea going on, and that's where you're eating and you're still getting diarrhea, starving doesn't help. We have to look at the specific food triggers, and usually they are high amine foods, so vasoactive amines, the same vasoactive amines usually that trigger migraines in migraine sufferers. And we look at the diet through a record of food and symptom diary, and we go through all of the things that may be causing an issue, and I ask patients to look at, you know, when did you flush? You know, write down when you flush. Was it because you ate a banana or some ham or a sausage or something an hour ago? And just see if there's any patterns, and then we discuss things again and see whether they are actually sensitive to these things. Some people aren't at all, and it's definitely not a list of foods to exclude. It's only if you have this reaction of flushing or diarrhea after you've had them. So obviously there's lots of things that you can cut back on, but we have to make sure that the diet is adequate, that it has high protein content, so you're not excluding things without really knowing what you're doing. Often people exclude lactose, but it's not lactose that's the issue, or they go gluten-free, and you know, gluten's normally fine unless you have celiac disease. So we have to make sure that you're getting enough nutrition and that you're absorbing everything. And if you are having lots of syndromic diarrhea, we make sure that you're having enough fluids, but also replacing electrolytes. So when you're having diarrhea, you're losing lots of salts, and electrolyte replacement is often required as well. Next slide. And I thought I'd mention constipation because it's actually quite a common problem, and I know for people with diarrhea, it's something that they wish they could have, and people with constipation really wish that they could go more, but it is a common side effect. And actually, when we looked at the side effects that people reported to us in a survey recently as a side effect of somatostatin analogues, actually constipation or not being able to go fully was the most common problem. So as dietitians, we look at, obviously, if it's a side effect, we need to try and help someone as much as possible, not stop treatment. But we look at fibre. Are you getting enough fibre? Are you getting enough fluid? If you are having a high fibre diet, you need a really high fluid intake to manage all of this fibre, which absorbs all the fluid in your bowel. We need to make sure that you're active enough to keep your bowels moving. It's always nice to, like the Romans did, always have a walk after a meal if you can. Just get your bowel upright and moving, let everything go through. As I mentioned earlier, so methane exhalers can have a problem with constipation, so we'd think about whether that was a possibility. Can you get your methane breath tests done locally? If so, then we would send you for a test. And we'd look at changing the diet. We may be introducing things like probiotics or fibre supplements, depending on whether you had, a risk of blockage and things like that. We might have more soluble fibre supplements. Okay, next slide. Okay, so vitamin and mineral monitoring is a big part of what we do. We can look at blood levels because deficiencies are often due to treatment. So, for example, if you have this pancreatic exocrine insufficiency where you're not absorbing food properly, or you've not had enough of the enzymes for so long, you can have malabsorption of those vitamins, so vitamin A, D, E and K. Or you may have problems absorbing because you're missing that part of your bowel or your stomach. So if you're missing a large part of your stomach and or the small, very last part of the small intestine, we'd be looking at vitamin B12 as well. There's a risk when you're on octreotide that you become B12 deficient too. There's also deficiencies that are directly caused by the tumour. And for example, that would be those tumours that produce too much serotonin, so where you have the carcinoid syndrome. The serotonin is made in large amounts, and they use up what should be your niacin, so your vitamin B3. And over time, often when people have been waiting for a diagnosis 10 years, they will present with signs of niacin deficiency, and that's forgetfulness, diarrhea as well, so not just the carcinoid syndrome diarrhea, and dry skin, so dermatitis. There's also other rashes and things to look out for, but that the deficiency causing symptoms actually is called pellagra, and that needs a doctor to diagnose that. We need to assess who requires vitamin and mineral blood tests. So often it requires a dietitian appointment to have a look and have a proper think about what deficiencies are likely for you specifically. There's no kind of panel of blood tests to send people for, because everyone's different and everyone's had different surgery, they're on different treatment, they've had the disease for a different amount of years prior to diagnosis. So it really is an individual assessment that we need to do. Next slide. So I just wanted to mention all the other nutritional problems that we deal with. So some people have stomas. So stomas are the opening of the bowel onto the skin and into a bag. So you can have an ileostomy or a colostomy, and if there's any problems with those, whether you're constipated with those, or you have a high output where there's lots of gas and diarrhea and things, we deal with that. and we can manage the fluid requirements around that as well, and electrolytes if needed. We deal a lot with intestinal obstructions, so I know a few people have mentioned that already today, and you know, we help with the most appropriate diet at that point. If it then becomes a larger obstruction, we go more into liquid diets, and then the final stage of dietary care would be parenteral nutrition, so where no food or fluid can get past that blockage. Where too much of the bowel has been taken away, we have a problem of short bowel, and that means that it's intestinal failure, so your body cannot absorb the right fluids, the right vitamins and minerals, and enough fat, carbohydrate and protein at that point, and we manage those. Over here we have specialised intestinal failure units that we send patients to. It may be different in other countries, but they're specialised dietitians who deal with that. We see people with more basic problems like acid reflux, and make sure that they're not being too restrictive on what they eat, but also around timing of eating, posture when eating, and you know, not eating and then going to bed, and the correct angle of sleeping to prevent acid reflux, because the acid reflux over time can then cause inflammation of the esophagus. We deal a lot with pre and post-surgical diets, and that's a very big area of research at the moment. Having specific drinks before surgery to get through surgery and out of hospital as quickly, and onto food as quickly as you can afterwards without any problems, without any infections. So that's a really big area of research that a lot of hospitals are kind of working on at the moment. Things like chyle leaks after surgery, where it's an accidental nick of the lymphatic system, and this liquid comes out, where we require a low-fat diet to kind of dry that liquid up and help someone recover better and get out of hospital. Of course, there's problems with diabetes, so whether it's caused by the NET or not, people with insulinomas, glucagonomas, we're looking at blood sugar control, what's the most appropriate diet for them. And sometimes, especially with things like glucagonomas, it's very hard to control, and we really depend on the medical treatment to work. There's things like refeeding syndrome, so where someone's not been eating for a number of days. It's very important that we reintroduce food very slowly, or we can get this thing called refeeding syndrome, where there's a shift of electrolytes, which is potentially deadly. So it's very rare that it happens, but we deal with that in a hospital setting. There's neutropenic diets, so if someone's been on chemotherapy, we're looking at their white cells, which are called neutrophils. If they become too low, we have to adapt the diet around safe foods to have, the foods that won't cause food poisoning and sepsis, so an infection from the food that you eat, or probiotics. So we speak about what's the safe diet during chemotherapy, and then obviously there's things like food intolerances that can result as bowel surgery. Often things like lactose intolerance post bowel surgery are only temporary. It's because the bowel is healing, and it takes 1 to 2 years sometimes to heal after surgery, and we also have to deal with other surgeries that may have occurred due to another disease, or removal of polyps and things like that. So I hope that's given you a quick kind of run through about our role. And I haven't mentioned COVID once during this talk. So next slide, please. So I hope everyone's keeping safe, and I've seen some pretty bad mask wearing at the moment on TV, Formula One and things. So on a serious note, please always remember to keep safe and wear your mask correctly. Thank you.
Is this Maya?